You know why they put oxygen masks on planes? So you can breathe. Oxygen gets you high. In a catastrophic emergency, you're taking giant panic breaths. Suddenly you become euphoric, docile. You accept your fate.
912, ambulance, 75-year-old male, back pain, 211 Silver Hollow Road, between Lean Road and Crosspatch Road.
What's up? Dr. McMahon. You know, it's now considered common practice to use carefully titrated supplemental oxygen in patients with acute exacerbation of COPD. That is, some patients with COPD, especially those that are chronic retainers or could be chronic retainers, and we'll talk about that more later, we like to titrate the supplemental oxygen to a pulse oximetry reading of 88 to 92% in these patients. We give just enough oxygen to prevent hypoxemia in these patients without causing dangerous levels of hypercarbia.
Oh, you're really letting the oxygen out of my tank here.
But why? What does the literature show? The short answer is, well, it's kind of complicated. There are currently 3 theories that look at this: the hypoxic drive, the Haldane effect, and VQ mismatch. So let's dissect the literature, take a closer look. The first theory we will discuss is the hypoxic drive. In 1949, an article was published describing 4 patients with COPD who were cyanotic from an acute exacerbation. What they noticed was that as these patients were given oxygen, their intracranial pressure would increase. This pressure would then normalize after oxygen therapy was discontinued. One of the patients even died as a result of this. After seeing this, they hypothesized that oxygen therapy could possibly lead to an accumulation of carbon dioxide in the body. So even in 1949, researchers cautioned against using too much oxygen in these types of patients. That same year, an article published in The Lancet described a coma from COPD that occurred during oxygen therapy, which clinically improved after oxygen therapy was stopped. This brought rise to the hypoxic drive theory, suggesting that there are 2 central drivers controlling respiratory effort in the body: hypercarbia, or elevated CO2, and hypoxemia, or too little oxygen. Because COPD patients spend their lives with chronically elevated CO2 levels, they no longer respond to this as a stimulus. Their only trigger to breathe is the low level of oxygen in their blood. This suggests that when you give supplemental oxygen to a patient with COPD, this removes the patient's hypoxic respiratory drive, causing them to hypoventilate, resulting in hypercarbia, apnea, and ultimately respiratory failure. The first study to really investigate this theory was done in 1980. They looked at 22 ICU patients with COPD and respiratory failure and measured the minute ventilation and partial pressure of blood CO2 in all patients first while breathing room air and then while breathing supplemental oxygen. What they discovered is that when patients were placed on supplemental oxygen, they had an initial drop in amount of minute ventilation. That is, they took fewer, more shallow breaths per minute. They started to hypoventilate. During this period of hypoventilation, the amount of dissolved CO2 in the blood started to rise. However, the minute ventilation soon recovered to near baseline levels, while the blood CO2 continued to increase. So what they found is that there was really no direct correlation between minute ventilation and the increase in CO2 measured in the blood. These and earlier studies confirmed that by giving too much supplemental oxygen to a patient with an acute exacerbation of COPD, their carbon dioxide levels can certainly increase. Interestingly, they also found that the more hypoxic a patient is on presentation, the higher risk they have of developing CO2 retention with oxygen supplementation. Investigators also suggest that hypoventilation from the loss of hypoxic drive, while plausible, is not the major contributing factor to CO2 retention after oxygen supplementation. So something else must be going on. That brings us to theory number 2, the Haldane effect. At equilibrium, the ability of deoxygenated hemoglobin to bind carbon dioxide is much higher than that of oxygenated hemoglobin. When supplemental oxygen is given, more oxygen saturates the open red blood cells. This shifts the equilibrium more towards the oxygenated form. Now there is nowhere for CO2 to bind. This increases the amount of CO2 that winds up dissolved in the patient's blood. This is known as the Haldane effect. This increase in CO2 is normally excreted by increasing minute ventilation. The patient literally tries to compensate by hyperventilating and blowing off more carbon dioxide. This helps to normalize the blood CO2. However, in patients with severe COPD who are unable to appropriately hyperventilate, the Haldane effect will ultimately win, and CO2 will increase. Researchers have only been able to blame about 25% of the total increase in CO2 on the Haldane effect. So something even bigger must still be going on. Let's look at a third theory, ventilation perfusion, or VQ mismatch, where V stands for ventilation and Q stands for perfusion. For now, just go with it. Normally, the ventilation of an alveoli and its perfusion should be pretty well matched. When there is a difference between the amount of air ventilating a part of a lung and the ability for the body to perfuse that part, a mismatch occurs. Two extremes of VQ mismatch may occur. First, when there is no ventilation of an alveolus, but there is adequate perfusion. This occurs when oxygen-rich air is not getting to the capillary beds to the alveolus, even though there is a good supply of ready and waiting red blood cells sitting in the capillary bed waiting for it to arrive. This is called shunting. Think of red blood cells as the boxcars of a train. They show up to the station and there's no passengers to get on the train. The train wasted all that time and energy and have nothing to transport. It shunted all of its resources to a station with no benefit. The second way in which VQ mismatch occurs is when there is adequate ventilation but there is no perfusion. This occurs when there is plenty of air flowing into the alveolus, but the oxygen can't transport this into the bloodstream. We call this dead space ventilation. Think of the oxygen molecules as people waiting for a train, but the train never comes. The body has protective mechanisms to optimize the VQ ratio. When alveolar oxygen decreases, for example in bronchoconstriction, local mediators cause pulmonary capillaries to this part of the lung to constrict. Using our train analogy, they send a smaller train since there is less people waiting to ride. This is much more energy efficient, and they can use the bigger train at train stations that are full of people who need a ride. This mechanism is called hypoxic pulmonary vasoconstriction. The strongest mediator for this mechanism is the amount of oxygen in the alveolus. When a higher concentration of oxygen is given, this inhibits the hypoxic pulmonary vasoconstriction mechanism in other parts of the lung. So now, alveoli with impaired ventilation are overperfused, and this leads to even worsening of the VQ mismatch. An article published in 2000 also studied the VQ mismatch during oxygen therapy. They looked at 22 patients with an acute exacerbation of COPD and infused inert gas into each through a peripheral IV. They measured the makeup of air expired by the patient as well as arterial blood gas readings of CO2 levels while on room air and then while breathing 100% supplemental oxygen. They classified patients into two distinct groups based on what happened to their CO2 levels while on oxygen. They called them retainers if their CO2 level rose by more than 3 millimeters of mercury, and as non-retainers if it did not. The authors then compared the minute ventilation, VQ matching, and dead space ventilation between the two groups. What they found was that VQ mismatch increased significantly in both groups. Minute ventilation decreased significantly in the retainers, but not in the non-retainers. And finally, alveolar dead space ventilation increased significantly in the retainers, but was unchanged in the non-retainer group. So since VQ mismatch increased in both retainers and non-retainers, the authors concluded that VQ mismatch cannot be the cause of observed CO2 retention. Further, because minute ventilation decreased in the retainer group but remained stable in the non-retainers, they suggested that oxygen-induced hypoventilation could be to blame. Although overall ventilation decreased in the retainer group, the amount of ventilation was increased to areas of the lung where there was a higher VQ mismatch. People showed up to a train station with no train. Remember, we call this dead space ventilation, and it was much higher in the retainer group. So while VQ mismatch increased in both groups, it is plausible to consider that it only caused hypercarbia in the retainer group because of the increase in dead space ventilation. To back this up, a 1996 study published in Critical Care Medicine compared data derived from a computer model of pulmonary circulation with data from a case series of patients with COPD to evaluate for specific factors contributing to CO2 retention due to oxygen therapy. They confirmed the three theories that we just discussed, that supplemental oxygen alters hypoxic pulmonary vasoconstriction and modulates the Haldane effect, resulting in changes in physiologic dead space. Most significantly, this increase in physiologic dead space was sufficient enough to account for the oxygen-induced hypercapnia that has been described in literature ever since the late 1940s. So what do we do with this knowledge? Well, as we learned earlier, patients most susceptible to oxygen-induced hypercapnia are those with the most severe levels of hypoxemia on presentation. So how can oxygen-induced hypercapnia be avoided without withholding oxygen therapy from these hypoxemic patients? 3 studies were published between 2002 and 2011 on the topic of pre-hospital administration of high-flow oxygen concentration in COPD patients. They showed that increased oxygen flow was associated with increased risk of death, assisted ventilation, or respiratory failure with an odds ratio of 1.2 for every 1 liter per minute of oxygen flow used. National guidelines for the management of acute exacerbation of COPD recommend an initial FiO2 of no more than 0.28. That's about 2 liters per minute on nasal cannula. These studies showed that oxygen therapy with an FiO2 in excess of 2 liters per minute is commonly used. It may cause or aggravate acute hypercapnic respiratory failure and is associated with a higher mortality. These studies showed that excess oxygen therapy is most often initiated during ambulance transportation, but is perpetuated by hospital emergency staff. Recognizing patients with an acute exacerbation of COPD and understanding this disease process is the first step in improving the acute care of these patients. Some studies, including this randomized controlled trial from 2010, give us the best insight for treating patients with an acute exacerbation of COPD. They showed that titrating supplemental oxygen to a pulse oximetry reading of 88 to 92% will prevent dangerous amounts of hypoxemia and significantly decrease the risk of oxygen-induced hypercapnia. This results in less respiratory acidosis and better outcomes when compared to higher oxygen saturation levels. This is also in accordance with the British Thoracic Society guidelines for the use of oxygen supplementation in patients with COPD. It is important to point out that this strategy only applies to patients with respiratory failure due to known or suspected acute COPD exacerbation. As always, approach your patients with an evidence-based mindset, because education is not just learning facts, but teaching the mind to think. Well, hope you learned something. That's it for now. See you next time. Thanks for watching.